Good afternoon. Welcome to Grand Rounds, slightly delayed. My name is Tom Ford and I'm the chair of Grand Rounds, along with Leslie Crichton, who hopefully has kept you entertained in my absence this afternoon. I'm delighted to introduce what we would have been in person, but now is over Zoom, but we tried to get there. It is Catherine McWilliam. Apologies for pluralizing you in my email, Catherine. I was expecting two of you to turn up, but that was a slip of the keyboard. But Catherine McWilliam is a consultant geneticist here in NHS Tayside. She has a particular interest in neuromuscular disease and the genetics thereof, and is the clinical lead for the Scottish Muscle Group, intriguingly. I've been chasing her for some time to come and do a Grand Rounds, and I'm pleased that she's agreed to do it today. And given that we're a little bit behind time, I'll shut up and leave it to Catherine. Thank you very much indeed.
So thank you for all your help around the organisation of this today, Tom. I was wanting to take the opportunity of having an audience to just tell you a little bit about the genetics department and introduce my colleagues here. So I hope you don't mind me taking a couple of minutes just to do that. We're a small department, but we do manage to get into most specialities across the hospital. So I thought that might be helpful just for you to see who we actually are. I'm trying to see if I can move my slide on. And so this is us. So the face that's probably most familiar to you is David Gowdy. He's our clinical lead here. He has been here since 1993. And he tells me his special interests are inherited skin conditions, neurogenetics and hereditary eye conditions, but I happen to know there's an awful lot more that he's interested in, and he often has a very wise word about a lot of our patients that we bring to him and bring dilemmas to him. We then have our genetic counsellors. Christina is the new person in our team. She and also Gisela mainly focus on cancer genetics, and Gisela has a bit of an interest around gynecological cancers. And then we have Grace Gibbon here, genetic nurse, and she manages our patients who are high risk for bowel cancer, managing the recall list for endoscopy. She also has recently been taking on an HHT MDT, and she is in fact working with patients with alpha-1 antitrypsin deficiency or who may be at risk of, and trying to establish their risk. And she also manages our low and moderate risk breast cancer patients that come through the department. Jackie Dunlop is the backbone to our counselling and nursing team. She's the manager there, and an unflappable woman who you will often get on the phone if you phone up our department. A face that will be familiar to most people is Jonathan Berg. He's a senior lecturer and consultant clinical geneticist. He does his general clinics in Perth, and he has an interest in prenatal genetics and rare diseases of blood vessels, as well as everything else. Kirsten Henderson is one of our genetic counsellors who also mainly works within cancer, but also cardiac and antenatal genetics and neurology. Kirsten has a special interest in psychological aspects around genetic counselling and testing. And so she's an excellent resource for our department when it comes to patients that are having difficulty in adapting to a diagnosis that's in the family. And she's also takes a lot to do with our teaching along with Jonathan. And then last but very much not least is Kirsten Patterson. She is a genetics nurse who has been working in the hospital for a number of years, so she knows lots of people. She has great contacts. She's my right-hand woman in a lot of ways, and I'm sort of trying to blackmail her into not retiring before I do. So that is the team. And then behind us are our laboratory colleagues, and in a lot of ways in genetics I think of myself as being the person that listens to these very clever people in the laboratory who really know the science and sort of trying to interpret it in such a way that it's understood by the patient. I'm not going to use, well, possibly the term to use is dumbing down, which I seem to be particularly adept at. So that's our team. I hope you don't mind me taking up a bit of time to introduce them, and I'll move on to what I was actually wanting to talk about today. So my name's Catherine McWilliam. I'm a clinical geneticist. I've been here since about 2013. And I do have a particular interest in muscle disease and indeed cardiac genetics. The prompt for today's talk was that myotonic dystrophy, as a rare inherited muscle condition, this year for the first time got its own awareness day. And I think that it's a sort of mark of the recognition of the impact of myotonic dystrophy on patients with this and their families. So one of the reasons for wanting to talk today was that often we find that diagnosis in myotonic dystrophy is made almost around a point of crisis. So at the birth of a congenitally affected child, or when a patient presents acutely. So I really wanted to make this something that people in all specialties would think a little bit more about, and it's just to raise awareness around it. So I'm going to talk a little bit around the science, a very small amount. I'm not a great scientist. And then just look at how myotonic dystrophy presents itself in a variety of healthcare settings. So myotonic dystrophy is thought to be the commonest inherited muscle disease in adults, with an instance of probably around 1 in 8,000, sorry, a prevalence of 1 in 8,000. And we've always thought that it's probably more common than that. And there certainly was research done recently using newborn blood spots in New York State in the United States, and they actually found a prevalence of 1 in 2,000. So a lot of these patients probably go undetected, and it would, it sort of suggests to us we should be looking for it more. It is a complex multi-system condition and differs in a lot of ways from other muscle conditions in that it has its impacts along throughout the sort of body systems, and it is quotably probably the most variable known disorder in medicine. And the infographic at the bottom just sort of indicates what the mutation actually looks like in myotonic dystrophy. We find in the DMPK gene, there's a region of the gene that has this number of CTG triplet repeats. And in the general population, in the normal population, the number of those repeats is usually between about 5 to 37. When you go over 50 repeats, the gene becomes more unstable. There's more of a predisposition to expand. Those number of repeats increase in size over the generations, and that's when we see the symptoms and the disorder associated with it. One of the reasons it's always been of interest in genetics is that myotonic dystrophy shows this phenomenon known as genetic anticipation. This is where we see worsening over the generations of the condition, and we now understand that that's because of this instability of those repeats, and that they do have a tendency to expand in number over the generations. And you can see here, looking at the picture on the left-hand side of the screen, that there may have been a grandfather here with 72 repeats who may not have presented with anything other than early onset cataract, but in the next generation the number of repeats has increased, and you might find that that's somebody who has ptosis in their sort of middle ages. And then particularly when passed down by a female that's affected, you see that the repeat number becomes particularly unstable, and this is where we see cases of congenital myotonic dystrophy arising. You can see this picture on the right-hand side of the screen at the top there. This is a picture from the old literature, and you can see those 3 generations there, with Granny looking pretty much like a normal Granny, for the 70s anyway. And there's Mum, who looks like she has some sort of reduced facial expression and ptosis, and then her own child with who's clearly been born with congenital myotonic dystrophy. And just to update things, there's a picture there from a more recent family, and this is a wee girl who's been born to a mother who probably didn't know that she actually had myotonic dystrophy. But actually, when you look at that picture, I think you can probably, certainly it feels to me like there are some features that could have been discerned there. But this baby did spend, I happen to know, around 4 months in the neonatal unit and had to be intubated and ventilated because of their weakness when they were first born. So it's worth saying that there actually are 2 types of myotonic dystrophy. The one we're talking about today is type 1, and it's more common than the rarer type 2, which is a proximal myotonic myopathy. They're both autosomally dominant inherited, but we don't see the same anticipation with type 2. And it's a different gene, different type of expansion. But it's just worth mentioning that there, but I'll skip through things for the interest of time. So just to give you a bit of an insight into why this is a multi-system disease, I thought it might be helpful to talk around this. So you have a cell here with the nucleus. We'll all know that the DNA is transcribed to mRNA, and then the mRNA is packaged up to move out of the cell into the cytoplasm, where it's translated into the proteins. Because of the expanded triplet repeats that we see in myotonic dystrophy, that DNA almost becomes sticky, and you get this expanded mess of RNA that gets almost stuck. So it's difficult to package that up. And you can actually see this using these certain imaging techniques, and you can see these small pink ribonuclear foci, and this is just where they have these clusters of expanded RNA. And what that means is that the splicing factors that are involved in packaging up our RNA actually is difficult for them to work. And this doesn't just impact on the protein product of the DMPK gene, it has impact on other genes and how their protein products are then packaged up and regulated. So we get this, what we call dysregulation of alternative splicing, and this affects many genes. And I think this illustrates quite nicely. You have down here at the trunk of the tree the triplet repeat that you see in the DMPK gene, and what it causes for other genes and their products. And so it gives an indication there are over 100, probably more, genes that are affected by this, and that may well be the root cause for the sort of multi-system pathology that we see in myotonic dystrophy. And you can see that there are genes here that have their action in the brain, the heart, and in the muscle, but there will be more as well. So moving on to, this is possibly what anyone who's studied for medical exams, if they're talking about myotonic dystrophy, will maybe talk about a GESTALT that we see in myotonic dystrophy, where you have this classic faces of frontal balding, bitemporal narrowing, ptosis. We often find that because of the muscle weakness around the face and head, that our patients have a nasal or dysarthric voice, and will often have a long face, particularly so with the early onset and congenital and childhood onset cases. And because it's a distal weakness that they tend to present with, we see the slow gait with a foot drop as being something that they maybe present with. However, it's not that easy, and anyone who's seen a patient with myotonic dystrophy will probably know that they don't quite tick all the boxes like lots of patients with lots of disorders. And that's why it's helpful to think about it in a speciality sort of way. What's the way they're likely to present to your speciality? So one way they present because of the muscle weakness and thinning is to the neurology clinic. And as the name says itself, they have myotonia, and they're one of a few conditions where you see this sort of very distinct myotonia, and this is nicely sort of displayed here with this video that my colleague Mark in Glasgow has shared. And classically, the sort of way to examine this would be to offer the patient to squeeze the finger, and then they have that slow releasing of the finger. And in fact, a lot of patients you'll find will take their other hand and move their fingers to release that myotonia. And this, from a perspective, for the patient perspective, is quite impactful on activities of daily living. If you imagine you go to put your key in your front door and you have myotonia, these are small things, but definitely impactful. And many patients will have their swallowing issues, and dysarthria are associated with myotonic dystrophy. Some will have muscle pain. This is not that common a feature, but it can look a little bit like fibromyalgia, so worth keeping in mind. And when we do CK in these patients, it's often normal or slightly raised, so it's not really a very good clue to the diagnosis.
3, 2, 1.
Study. The other way that they may present in the neurology clinic is with the cognitive issues, and this is something that's becoming more apparent and better researched in the last sort of 5 to 10 years. And lots of these patients will have problems with learning difficulties, particularly for the congenital and childhood onset, but they also can have a particular way of thinking. So apathy may be a problem, maybe a rigidity of thinking, and there can sometimes be a little bit of impaired social cognition, and that combined with the fact that you can be faced with a patient who actually has a paucity of facial expression, it can be very difficult to read them, and actually those things all combined can make it difficult to manage them, and they're very easily dismissed because of that. So it's certainly something that we keep in mind when we're trying to arrange their sort of ongoing investigations if need be. They can present with excessive daytime sleepiness, and that is probably caused by central effects, but also the sleep apnea, and we know they're at risk of that. So there are probably two different things with slightly different mechanisms happening there, but they're certainly at risk of that. And they often don't report it. It's often their families, as you can imagine. So these patients sometimes do present to the cardiology clinic, and this can be for a number of different causes. And if we think back to that long, the long list of genes that may be impacted on by the DMPK triplet repeat, that gives us a feel for why that might be. So about 15% of them will present with a cardiomyopathy. And this is usually dilated cardiomyopathy. Many of them have a conducting system disease, and in fact you can see the ECGs at the bottom of the screen here are from the same patient over a 10-year interval, and they often start off with lengthening their PR, a broadening of the QR complex, and then this can move into a frank atrial sort of dysrhythmia. In the past, we did see these patients presenting with sudden cardiac death, but more recently, because of pacing, that's probably something that we've made a difference in. And certainly within the Scottish Muscle Network and our management clinics, we try to have in each centre a cardiologist that has a particular interest in seeing these patients so that they can get their ECGs reviewed over time, and the intervention with a pacemaker would probably be at an earlier stage in time than if you saw these sort of changes in somebody who doesn't have myotonic dystrophy. So these patients will often end up in the respiratory clinic, and we often refer them to sleep clinic because of their excessive daytime somnolence for sleep studies, and some of them will be offered support with their ventilation overnight to see if that helps with their daytime somnolence. But we do know there's sleep disordered breathing, and it's very difficult to unpick all these things, and we're very glad for the support that we get from Tom and colleagues. But this wee graph here just shows that this was a random selection of patients that were seen in the Glasgow clinic, and these were not screened out for their Epworth score or any of these things. It was just a random selection of patients who would go along, and you can see that the vast majority of them do have sleep disordered breathing. Because they can get problems with their bulbar function and swallowing, they are at risk of recurrent infections, and this can be worsened by muscle weakness, but also lead to aspiration and problems associated with that. So we do try to keep an eye on that as well, and often refer them on to speech and language therapy around their swallow. They can also present to the gastrosurgical clinic with sort of reflux and probably gut dysmotility. The problems that they have with their skeletal muscle probably extend into their smooth muscle around their gut. Often they'll present with IBS-like symptoms and indeed continence issues, which is something that is often difficult for them to discuss. And we've started taking a sort of fairly proactive approach around that, with actually asking them directly and seeing if we can support them in any way. And I think this graph here, that was a piece of work that we did a few years ago in Scotland, where we had an anonymous questionnaire for patients to fill in after the appointment, and then to put it in a box for us to keep it anonymous, because most people don't like talking about these things. But actually you can see this as a significant problem, and again affects their activities of daily living. Often our patients have elevated liver transaminases, and for reasons that are not fully understood, but they may well have increased tendency to non-alcoholic fatty liver disease. And there's a suggestion of impaired contractility of the bile caniculi as well. One of the hardest sort of presentations with myotonic dystrophy is, I guess, around anaesthetics in ITU, in that these patients are often very sensitive to depolarizing muscle relaxants. And so we'll see that they can present with masseter muscle spasm. Sometimes they'll find that a cold theatre may precipitate myotonia, and they are particularly sensitive to sedative analgesic. So it's something that we feel, if we can identify who these patients are, then at least when they are going in for procedures, then the anaesthetic staff are aware of the risks. And we would suggest that because they are at risk of respiratory suppression, that if they're booked in for a procedure requiring an anaesthetic, that they should have an HDU bed available to them for such a procedure. There have been horror stories of patients that have gone in for a day case and then have been the last person to leave the day surgery or have to be admitted overnight. And worst case scenario, a patient who's left unmonitored and goes into respiratory failure associated with this. So we do have anaesthetic guidelines on the Scottish Muscle Network website, and we make sure that we involve our anaesthetic colleagues in the sort of creation around those guidelines. They can also present to the opticians or indeed to the ophthalmology clinic, and particularly so with the ptosis, which is fairly readily seen, but they are predisposed to premature cataract. And the pictures here that I've stolen off the internet, Gannochy or some such place, mostly because they're quite nice pictures. The picture on the left there shows what we describe as a Christmas tree cataract, and I think this can progress onto the stellate cataract that you see on the right. So very seasonal, but fairly characteristic in myotonic dystrophy, and worth being considered if you do have premature cataract. And certainly we have wondered before whether or not there should be an automatic reflex to test someone for myotonic dystrophy if they present at less than 50 years with cataract. But in places where that approach has been taken, the yield has been fairly low, but it's certainly something that could be reconsidered, I guess. And then something that won't labour too much is around the child development clinic. These patients will sometimes present there with motor and global developmental delay, with learning difficulty, and when you ask back, there's often a history of feeding or respiratory difficulties in the neonatal period. When they present like that, they often have joint contractures and may well have spent a considerable amount of time in the NICU. Interestingly, they tend to grow out of these problems, and take you back to one of my earlier slides, the young couple with the baby that was intubated and ventilated in NICU. The wee girl here on the right there is actually that same baby a few years later. So they do get better. And while they start off very weak, and that's one of the reasons for referral to genetics early on, we recently did a patient, well, not recently, a few years now, pre-COVID, did a patient support day for myotonic dystrophy, and we ran a creche. And I think we all took our turn in the creche, and we were all struck by how strong these children actually are. And once they get past their early issues, they do have their learning difficulties and developmental delay, but they are strong. And so fairly challenging in a soft play area, and probably more so for their families, especially when it's been inherited from an affected parent. They often have fine motor difficulties, and the continence issues in children with early onset myotonic dystrophy are fairly profound. There are other things that myotonic dystrophy is known to affect. There are our endocrine colleagues are definitely well placed to see these patients, as they often present with thyroid problems, parathyroid problems, and insulin resistance. And they can present with hypogonadism, spelled properly next time. And this can affect their reproductive health with subfertility. And the women often complain of menorrhagia, and that can be quite difficult to manage. And more recently, there seems to be a presentation around altered sort of immunological response, and they often seem to have a low IgG. We haven't gone as far to test that routinely, but certainly something that we're keeping in mind. So to sort of summarise key points for clinical care, myotonic dystrophy is a complex multi-system disorder. In genetics, we often are involved in diagnosis, and then we pass our patients over to people that are much better suited to looking after patients and individual problems. Because of the multi-system nature of myotonic dystrophy, we hang on to them in genetics, and the way we've done that in Scotland is that each genetic centre has somebody who takes responsibility for following up our patients with myotonic dystrophy. In a lot of ways, it would be well done by a GP, and certainly that's what happens in Grampian. There's a GP there who has a special interest in genetics, and she's very well placed for picking up problems that they have. I'm no GP, and I certainly don't have the expertise that they do, but working closely with Kirsten Patterson, our genetics nurse, who sees the vast majority of these patients for follow-up, we try to manage their problems and almost troubleshoot any issues that are arising and refer them on to the people that do know how to manage the problems that arise. So you will no doubt have had letters from us around our patients with myotonic dystrophy. We follow a guideline that was created over 10 years ago, I think, as Tom said in the email introduction. We put these guidelines together using best practice and consensus, using sign nosology at the time, but we have been following them, and they're updated every 2 or 3 years. And just last year, the Myotonic Foundation, which is an international organisation, came up with their own care recommendations, and ours aren't very far off that, although there is a slight difference where the Myotonic Foundation's recommendations are slightly more Americanized than our local guidelines that are done in conjunction with specialists across Scotland. So we do try to look out for potentially avoidable causes of morbidity and mortality in these patients. And if we are able to detect them early, that is, gives us the opportunity to do that. And so I suppose for people listening today, the question should be what to do if you suspect myotonic dystrophy. I think firstly and foremost, the test for myotonic dystrophy is a simple genetic test. Because it's a triplet repeat disorder, the test can be done and you get a fairly concrete yes or no, unlike some genetic tests that I'm sure that many people will be familiar with, where we sit with uncertainty at times. With myotonic dystrophy, that tends not to be the case. So I would have a very low threshold for testing for it if you suspect it. If there is a predominant neuromuscular picture, then refer to neurology, but if it looks more multi-system, we'd be happy to see them in clinical genetics for review and arranging the test there. But given waiting times and things like that, I think that doing the test yourself, this is not one that would get bounced back to you for more information. We would just do the test. So to introduce my motley crew across Scotland who manage patients with myotonic dystrophy, we have our friends in the north. Helen is there, she's our GP that works up there. In Glasgow, we have Bob Valentine and Mark Hamilton. Mark Hamilton's given me most of these slides today. Across in Edinburgh, we have Yvonne Robb, and then there's Kirsten and myself in Tayside looking after these patients, mostly Kirsten, to be honest. We are also involved in research with Professor Darren Monckton, who's at the University of Glasgow and is a bit of a world leader around myotonic dystrophy and indeed other triplet repeat disorders. And we do collaborate quite closely with Darren around our patients. I would, I'd signpost you to the Scottish Muscle Network website, and the professionals page does have links to our guidelines, and we sort of try to fairly regularly update this. One of my responsibilities is to keep an eye on this. So that's a useful link, I would think. And then this came from the myotonic dystrophy support group around tips for diagnosing myotonic dystrophy, and just worth keeping in mind if you have a patient that you just have a feeling that there might be something muscle going on. And thank you for listening. That's all I really had to say today. I hope I've not bored you too much, and happy to take any easy questions.
Thanks so much, Catherine. That's really, really interesting. As you said in one of your earlier slides, it's my knowledge of myotonic dystrophy, I think, extends to what I learned at medical school, which is that, you know, that frontal pattern baldness, cardiomyopathy, cataracts, and so it's great to get an expert view of what we know now that I wasn't taught in 1997. So the thing that intrigues me about this slide particularly, being tired all the time. We are living in a second pandemic of being tired all the time. We get a lot of referrals for being tired all the time, to the point that we, certainly in respiratory medicine, and we get a lot of them, we can't see everybody. And we're trying to do screening tests to pull out the people who've got something fixable, but a lot of it is deconditioning and weight related, etc. What's your advice on not missing the important person who sat out there with myotonic dystrophy that I'm looking at on my vetting and saying this is just someone who's tired all the time?
I think the tiredness is, we're going to find that in many different presentations for lots of different conditions. But I think if you have that with something else that might trigger this thought, then it's something that shouldn't be dismissed. But I think if they have sleep apnea, is that something that should trigger it? Or if you see them face to face and you think they have that GESTALT that we talk about, if there's any sort of family history of, maybe putting a question out around family history, is there any genetic problems in the family? Anyone else like this? Anyone troubled with, their grip? And is it difficult to, turn a key in the lock? Or those sort of questions may be relevant. And
do you have a handle on how many people are undiagnosed, in Tayside? Is there a sort of prevalence that we should have 400 and we've actually only got 100. I'm pulling numbers out of the air. Have you got a sense of that?
I do. I know how many we have that are diagnosed, and we don't see them all because some of them just fall off the radar and we just can't get, we try our hardest to see them and they just won't appear. I don't have a feel for what number we should be looking for. I could probably go do the sums, and probably should have, but I can certainly let you know which proportion you need to look out for.
There are a couple of comments in the chat from anaesthetic colleagues thanking you for the signposting to the SFN anaesthetic guidelines, which people weren't aware of, but they're very grateful for. In my very, very brief time doing anaesthetics, there were certainly some people who took a long time to wake up for anaesthetic, and we were thinking, what can go on? I suspect my anaesthetic colleagues, or they know a lot more than I do, and it's probably not a common thing, but useful to know about these resources. So does anybody else have any questions, comments they'd like to thrust at Catherine? I'm grateful for everyone's patience at the beginning of this as we try to wrestle with the IT. There's a hand up, and it is from Paul Newey.
Hi, Catherine. Thanks for that talk. Sorry, I missed about 5 minutes of it in the middle, but I just wondered with the trinucleotide repeat expansion, whether there was any kind of novel therapies with gene editing or, alterations in or modifying transcription or splicing that would mean that there are kind of, new therapies in the offing.
It's a lovely thought, and certainly, so Darren Monkton, who is the professor in University of Glasgow, who does much of this research, he's involved in research around Huntington's disease, and obviously there has been recent interest around therapeutics for Huntington's disease, and it's a very similar model. Unfortunately, myotonic dystrophy is not as appealing as things like Huntington's disease. I don't know if it's the patient group, but there is never enough funding for this. So we only can hope that by with the emergence of therapies for other triplet repeat disorders, that maybe that will feed down to myotonic dystrophy as well. And certainly it's something that having spoken to Darren about it, that he does do a lot of work with Huntington's disease, and he hopes that that would then move into being applicable within myotonic dystrophy. So, it is out there, but it's certainly not happening as yet. But thanks.
Okay. If we want to do the test, is it straightforward to find on the genetics bit? Do I just search for myotonic dystrophy and it pops up?
Maybe one of our scientists can answer that question for me quickly, but it's a fairly easy thing. If on our ICE page you go into rare and inherited and click that box, you can probably just type in myotonic dystrophy and it will happen for you. You just need to make sure that you've consented the patient to say that you would be doing the test. It's a fairly quick turnaround for this one, not extended to the 3 months that I'm sure you're all fed up waiting for, but probably about a 6 to 8 week turnaround for this test.
Righto. The only other thing that just jumped out is the cataracts thing, as someone who's had them at an early onset. But I suppose it's not the only cause of early onset cataracts. But what you're saying is if people do present to ophthalmology with early onset cataracts, it's looking for the other things. Those are particularly your squeeze grip test, etc., and for other things. Okay, right. Speaking of ophthalmology, next week at Grand Rounds, Sonali Tarafta will be here. I'm not sure whether he'll be here in person in the Gannochy or on Zoom. We'll have to see what the IT does. But she's going to talk about vitreoretinal surgery, the advances that have been made in the last few years in terms of local services. I think she's going to discuss a couple of cases. Vitreoretinal surgery is close to my heart. I'm sure you'll all realize, as I've been the beneficiary of excellent VR surgery here in Tayside. So I'm personally looking forward to hearing the talk. She also does an awful lot of work in terms of global citizenship and is a national prize winner for her global citizenship work. So please do tune in next week, where she'll be talking about some of the work she's done on a global stage. Thanks again to Catherine. Thank you for your forbearance in terms of the IT and getting all this sorted. Get there in the end. Thank you very much for toughing it out and then waiting for a fantastic talk from Catherine, which I very much enjoyed. Thanks, Catherine. Thanks, everyone else. And I'll see you next week.